Welcome to 5 to Thrive Live. I'm Dr. Lise Alschuler, the host of tonight's show. This is 5 to Thrive Live, co-hosted by Carolyn Gazella and myself. And tonight, it's my pleasure to be the host. I'm looking forward to the show tonight very much. And if you are tuning in for the first time, 5 to Thrive Live is a show inspired by the work of Carolyn and I in the area of integrative cancer prevention and treatment. We are the authors of 2 books on the topic of cancer, The Definitive Guide to Cancer, and our most recent book, 5 to Thrive, Your Cutting-Edge Cancer Prevention Plan. This show is all about bringing you guests who have expertise in various areas to both inform and inspire you to lead a healthier life, a more informed life in the face of cancer. And we could not do this without the very generous support of our sponsors, and I would like to thank each of them. Our sponsors include Cetria Glutathione, Cognizin Citicoline, Tomorrow's Nutrition, Natural Health International, and Naturopathic Specialist Clinic in Scottsdale, Arizona. So we really do appreciate our sponsors. And if you would like to learn more about us and or you would like to get more of what you're hearing on these shows, please go to our website at 5tothriveplan.com. We have a digital magazine, which is a fantastic new kind of experience and activity for us. It's a really nice, very colorful digital magazine, interactive multimedia, lots of great information. You're welcome to subscribe to that. It's a very low subscription price, just there for you to get information out. You can also sign up for our Thrive Thoughts, which is the subscribe button, and that will give you our weekly radio show in an email every week. And also we send out a Thrive Thought every week, which is typically a short, inspirational reminder about some aspect of healthy living, or sometimes we summarize a recent article, or sometimes we send out recipes like we did last week. So all good stuff right there for you on 5tothrive.com. And I'm going to introduce our guests now, but I do want to also just remind you that you are welcome to ask questions throughout the show, and you can do that by opening up the chat room on your screen. They're both there's 2 chat rooms collapsed on the lower right, and if you open up the general chat box, you can enter your question. You don't have to sign in. You can do it with your assigned name, and I will be monitoring that throughout the show. So I encourage you to do that. Okay, so let's get to business here. We have a very important topic tonight, and also a very important guest to tell us about this topic. So joining me tonight is Dr. Lise Chrysopoulo, and Dr. Chrysopoulo, referred to as Dr. C, which I'm going to do from here on out as well, is certified by the American Board of Plastic Surgery and was recently named one of America's top surgeons. Dr. C has been a recipient of the San Antonio Business Journal's Top 40 Under 40 Award, and he's been featured in I lost my place here. He has been featured on KENS 5 News for using new technology to optimize breast reconstructive surgery. He was a featured guest on De Leon's Dialogue, which is a radio show about surviving breast cancer, and his areas of special interest include advanced breast reconstruction techniques, minimally invasive, which means short scar surgery of the breast, cosmetic surgery of the breast and body, and scar healing. And we're going to learn a lot more about all of this, because that is really the topic of tonight's show, which is breast reconstructive surgery. This is something that, as a naturopathic oncologist, I have many conversations about. This is quite an interesting and sometimes very confusing decision point for people undergoing breast surgery, particularly mastectomies, and kind of knowing what to do and what their options are and when the best time to do it. So we're going to learn all about that and more from our guests. So Dr. C, welcome to 5 to Thrive Live.
Thank you so much for having me.
Well, I am, as I said, very delighted to have you. It's not often that we have the chance to get such an expert talking about a topic as important as this. So tell us, just before we go to our first break, could you just tell us what breast reconstruction is? And that might be a bigger question than we have time for. We can break it down a little bit further later in the show. But if you could just give us an overview of what this surgery means and when it's indicated.
Sure. Well, it means different things to different people. I guess to sum it up in one sentence, it's making a breast cancer patient whole again. So that's physical, emotional, mental, psychological. For many people, it's also a statement of intent, because if they had no plans on beating breast cancer, they wouldn't care about being whole. I'm stealing that phrase from a previous patient, and when she told me that, I found it kind of quite inspiring. But breast reconstruction isn't for everyone. There are some ladies that, or men for that matter, that prefer to just leave things as they are after their breast cancer treatment and breast cancer surgery. So you don't have to have it. But I think it's important for everyone to know that they have that option.
Mm-hmm. Yeah, absolutely. And I think that, it's, I'm going to ask you a little bit more about this and about why it might be so important for women to consider, particularly in the case of this show. We're going to focus a little bit specifically on cancer and breast reconstruction surgery in relationship to breast cancer. So we'll take that up. We are going to take our first break, so we'll come back in just a few minutes. Welcome back to 5 to Thrive Live. If you've just joined us, my name is Dr. Lise Alschuler, tonight's host of the program. Tonight, I am joined by Dr. Minas Chrysopoulo, who is he's a plastic surgeon, and he is talking to us about breast reconstructive surgery. If you have questions for Dr. C, please enter them into the chat room collapsed on the bottom right of your screen. I'll be checking that throughout the show. So I'd like for you, if you could, Dr. C, to explain. Let's start kind of basic and maybe just explain what breast mastectomy surgery is. And, because that's really the most common, I would imagine, most common reason that people would be in a situation to maybe consider reconstruction surgery. So let's talk about mastectomy first.
Sure. So a mastectomy is one of the surgical treatments that's offered for breast cancer. The other option is lumpectomy, which removes just the portion of the breast that's involved by the cancer. Mastectomy traditionally is the gold standard, so in terms of decreasing the risk of the cancer coming back, so decreasing the recurrence risk. What happened was actually historically mastectomy many years ago was usually very, very debilitating. And it was a horrendous procedure to go through and live with in terms of the physical and cosmetic results. So that actually led to people wondering whether they needed to remove the whole breast or not. And then lumpectomy came about as a treatment option. Then, looking at the results of lumpectomy, breast cancer doctors realized that if you had a lumpectomy, your chances of getting your cancer back in the remaining tissue was higher than if you had removed the entire breast with a mastectomy. So the mastectomy obviously removes the entire breast. Then what they did was they looked at what happens if you add radiation to the breast after lumpectomy, and they found that the results between lumpectomy and radiation were very similar to mastectomy in terms of survival. So because the mastectomy was such a debilitating procedure, breast conservation, in other words, lumpectomy and radiation, took off and became more popular. Well, then what happened, ironically, is that people didn't look at mastectomy anymore in terms of reconstruction because the reconstructive techniques way back really weren't that good. Well, since then, and since lumpectomy and radiation has become more popular, reconstructive techniques have really come a very long way over the last 2 decades, really. And so now, in terms of cosmetic results, mastectomy and reconstruction in the correct setting and in the correct patient can give some really incredible results.
Mm-hmm.
So why do women choose one over the other? Well, there's no right or wrong for everyone. It's very much an individual choice. Some women feel that they would be better off just keeping as much of the breast as possible and going the most minimalistic route and just having a lumpectomy and radiation. And then they continue to monitor the breast with self-exam and mammograms and all the rest of it. And that's that. But that's the least invasive surgery. They'll have chemotherapy, typically radiation, and then that's it. Other women feel like they really don't want to go through this again. So even if it's a small tumor and it could be easily treated with a lumpectomy and radiation, more and more women are choosing the mastectomy to remove the entire breast because, as they say, I just want to be done with it, doc. I don't want to carry on with mammograms, and I don't want to be fearful of it coming back. And now, in reality, even after a mastectomy, breast cancer can come back, but the recurrence rate is less. And you don't have to go through the yearly mammograms anymore and all the monitoring that they typically do, other than self-exam, which I still personally recommend. The other interesting trend has been actually a trend towards doing mastectomy on both sides, doing a prophylactic mastectomy on the non-cancer breast. So here you see a large spectrum. You've got the one end of the spectrum, which is the most conservative surgically. You've got lumpectomy with the radiation. And then the other end of the spectrum, you've got removing not just the entire breast that's affected by cancer with a mastectomy, but also doing a mastectomy on the prophylactic breast. And we're seeing that more and more in young women with aggressive cancers who just don't want to live with the thought and fear of a future cancer because they're in their 30s or early 40s. So there's a huge spectrum of choice. It's a very personal, there's no right or wrong way to go.
Right. Well, one of the things that if somebody does choose to have the mastectomy, I think one of the things that you alluded to, which has made this decision in some ways easier, is the reconstructive options afterwards. So and we have a question in the chat room, but before I ask you that question, it's going to require that you orient the rest of our listeners a little bit to reconstruction. So if you could tell us a little bit about the options for reconstruction, and I know that you could speak in great detail about this, but maybe just at a kind of an introductory level, help us understand how this can occur.
So reconstruction can be performed straight away at the same time as the mastectomy, which is ideal. And so most women that have early stage cancers are candidates for immediate reconstruction. So reconstruction at the same time as mastectomy. But when, any woman that's had a mastectomy can have a reconstruction after the fact. It can be many years after the mastectomy, if need be. That's called delayed reconstruction. So reconstruction can be performed at any time. There are lots of options. The option that most people are familiar with are implants. That's the same implants that are used for cosmetic breast augmentation, enhancement, either saline or silicone. And the alternative to implants, which we actually focus on in our practice, is using the patient's own tissue, which offers the benefits of not using a foreign material in the body and using your own. It's usually fat that we use. We can use fat from the lower tummy. We can use fat from the buttock region, from the thigh, and also from the back. Our most common procedure, the procedure that most women want, uses the lower tummy, which that's called a DIEP, deep flap, and that uses skin and fat from the tummy That's an evolution from an older technique that was pioneered in the 80s called a tram. A tram flap uses the same tissue over the lower abdomen, the lower tummy, the skin and the fat, but unfortunately also sacrifices part or all of the abdominal muscles. So in a lady who's particularly having both breasts reconstructed, you really don't want to lose all your stomach muscles. Then you're limited in terms of what you can do, especially if you're very active. You have a higher risk of getting a hernia. The recovery is harder in the hospital. It's longer. It's more painful. So the deep flap, it really is the latest evolution. It's become the gold standard, and that moves the lower tummy skin and fat, so the patient still gets a tummy tuck. That tissue is disconnected from the body and transplanted up to the chest. And so because it's been disconnected, it has to be reconnected. So all the plumbing has to be redone, the arteries and the veins, so blood flows in and blood flows out of the new breast. And that's where specialized training comes in. But that procedure allows you to save all the abdominal muscles, and the vast majority of patients can get back to doing exactly what they were doing before in terms of activity. We have farmers, we have triathletes, we have marathon runners, we have police officers. Breast cancer doesn't care who you are, doesn't care about the economy, doesn't care about what you do for a living. So we have patients from all sorts of walks of life.
Mm-hmm. So, before you move on from this particular procedure, the question in the chat room is regarding the deep procedure. Okay. So I wanted to ask you, and I think there's sort of two questions, both of which I find interesting myself. So one question is, can cancer occur or recur in any way in the transplanted tissue? That's the first question, and I'm just going to throw both of them out there. And the second is, this particular individual, it seems, is considering this procedure 4 years out from her mastectomy, and I think you answered this, but wanted to know specifically if there's any additional challenges to the surgery or tolerance to it at this point in time. So the first question: can cancer occur in the fat that's transported and brought up, and or not? And then the second question is it difficult to do 4 years out?
Okay, so breast cancer doesn't grow in the transplanted, or doesn't grow from the transplanted tissue. So the transplanted tissue is fat. So a breast cancer won't grow from fat. However, like I mentioned before, even after a mastectomy, you can get a breast cancer come back, and it can recur. When that happens, it happens in a breast cell that's been left behind under the skin or against the chest wall muscle or something like that. Once that recurrence kind of takes hold, then like any cancer, it grows into the surrounding tissues. So you can suffer a recurrence in a reconstructed breast, but the recurrence doesn't arise from the transplanted tissue that was moved to reconstruct the breast. Does that make sense?
It does. And just as a follow-up, before we get to the second question I asked, you may address implants later and some of the challenges that implants pose to monitoring.
Sure.
Do you have the same challenges in terms of, diagnosing recurrence with this procedure?
Well, the mainstay of diagnosing a recurrence is an MRI. That's what most oncologists will perform for follow-up. It's not a routine, frequent exam for most people, but the MRI is what's used in our community particularly, and that's regardless of the type of reconstruction, whether it's an implant or tissue. The self-exam is something I tell patients to carry on performing It's especially important if a lady has had a nipple-sparing mastectomy, which preserves the nipple and the areola. But most cancers, when they recur in the region of the mastectomy scar, so it's very superficial, so a lot of the time you can feel it. So whether it's an implant or tissue, most of the recurrences you'll be able to feel.
Okay.
And the second question was the timing. The timing in itself doesn't pose any additional issues. So there's a misconception out there. Some ladies come to us, and it's been 5 years, and they'll say something like, well, I was thinking about this about a year after my mastectomy, and then life took over, and I was trying to get back to my life and trying to get back to as normal as possible a life, and then things happened, and then it was 4 years before I knew it, and then I thought, oh, it's too late now, I can't do it. Well, insurance will cover it regardless of the timing, so you don't have a set timing window. You can't miss the boat. You can do this a year after your mastectomy. You can do it 10 years after your mastectomy. It's in terms of the difficulties of the procedure, that the timing of it is really neither here nor there. There can be challenges with some patients because of previous treatment. Radiation can make it a little bit harder, but we deal with that all the time, so that's definitely not a contraindication to reconstruction by any means. But it can make things a little bit harder in terms of scarring and what have you. But other than that, really, if anyone is interested in reconstruction, regardless of when they had the mastectomy, I would really encourage them to go and talk to someone about that.
Mm-hmm. So that's very important information. And I think before we go to our next break, let's maybe just lay out some of the other options for reconstruction. Particularly, I'm thinking about implants because I think that's the biggest, perhaps, contrast.
Yeah, sure, absolutely. So implant reconstruction is typically performed in 2 stages. The first stage is the placement of a temporary implant called an expander. That's basically an empty implant that's filled over time with saline, with salt water. That's what makes the implant, the tissue expander, bigger, and what makes the reconstructed breast bigger, obviously. And then once the physician and patient together have decided that they're done in terms of the ballpark overall size where they want to be, another surgery is needed, and you take the patient back and take out the expander and put in the final implant. Typically, the patient will also need a nipple reconstruction if they haven't had a nipple-sparing mastectomy, and that's usually performed at a separate stage in our practice. And then a final stage is required for the tattooing of the nipple and the areola to give it its color. So the typical traditional implant-based reconstruction can require up to 4 stages, 2 of them being surgery under general anesthesia. Now, there is increasing popularity in trying to do the implant reconstruction in 1 stage, and that comes under different names. They all mean the same thing: the allodome 1-step, or direct to implant reconstruction, or single stage. They all mean the same thing, and that's basically that the final implant is placed at the same time as the mastectomy, so that everything is done in 1 procedure. The right candidate for that procedure can end up with an absolutely great result. I would caution people about jumping to that procedure and demanding that procedure because not all patients are the right candidates for it. And if you're not the right candidate, that single stage ends up being anything but 1 stage to get it right. So that's the general kind of implant reconstruction. The other thing about implants is that we're doing more and more now to try and decrease the risks associated with implant reconstruction. Implants sound much easier than using your own tissue. You're not operating on another part of the body. All the surgery is confined to the breast. But there are issues with them. Like any surgery, there are risks. But particularly with implants, the main issues are that over time they can become hard, and that's because a shell of scar forms around the implant, and that can get thick and hard, and it can compress the implant and change the way the implant and the reconstructed breast looks, and it can also cause discomfort. The other issue with implants is that a lot of the time you can see the ripples in the implant through the skin because there isn't much tissue left behind after the mastectomy to cover the implant. So the implant typically goes underneath the muscle, the chest muscle, so that you have as much padding as possible over the implant. And then we use something called alloderm, which is a cadaver product, which is basically human skin that's been treated so that all the immune cells are removed. That's also placed inside the breast to cover the part of the implant that's not covered by the chest muscle. Now, in order to decrease the risk of that rippling, because even though you put the implant under the muscle and you put the alloderm to cover the rest of the implant, even though you have that padding, it's not enough in most people to decrease those ripples. And you can still see those ripples. It's like waves in the implant through the chest skin. Now, to decrease that, we're doing a lot of fat injections now, and that's typically done at the second surgery when the tissue expander is removed and the final implant is placed. At that surgery, we're typically injecting fat under the skin to increase the padding. And that's called fat grafting or lipofilling. And that increases the padding over the implant and decreases the risk of rippling, visible rippling long term. Mm-hmm. So,
very, very interesting, and I'm learning a lot. Unfortunately, I have to interrupt you because we have to take another break. But when we come back, we'll just pick this conversation right up where we left it. So we'll be right back. Welcome back to 5 to Thrive Live. I'm Dr. Lise Alschuler, tonight's host. I have Dr. Minas Chrysopoulo with me tonight. He is a plastic surgeon specializing in breast reconstruction, and he's giving us a really wonderful overview of this very fascinating and, in many ways, tremendously life-changing opportunity for women who have had breast cancer. And I'd like for you to kind of pick this conversation up. And first of all, I want to give you the opportunity, if there's any other additions to the procedures that you want to share with us. And then kind of on the tail of that, I'd also like for you to talk. You mentioned earlier that the best timing is immediate reconstruction. So I'd like for you to address whether there's any impact to having that kind of surgery, because a lot of women will get the mastectomy and then have to undergo chemotherapy, and if there's any impact to how they receive the chemotherapy and how they heal from the surgery.
Yeah, that's a great question. Well, first of all, all physicians involved in breast cancer treatment focus on their part of the breast cancer treatment. So, and it's the treatment of the breast cancer is obviously, goes without saying, first and foremost, it's life before breast. But unfortunately, only 30% of women that are candidates for reconstruction are told about the option. So most of the women that we see are for delayed reconstruction. The sad part is that most of those that we see for delayed reconstruction would have signed up for immediate reconstruction if they had been given that choice. So they've been, living without a breast, and they would have loved to avoid that if given the option. I don't know exactly why that statistic is the way it is and why so few people are told about reconstruction. I think that you've alluded to one possible contributing factor, and that is a misconception that reconstruction will delay breast cancer treatment. Studies have been performed. They've looked at it. They've looked at patients that have undergone mastectomy only versus mastectomy and reconstruction, and it's pretty definitive that reconstruction does not delay chemotherapy. So now, does the occasional patient have a wound healing issue or something, and chemotherapy can be pushed back by a couple of weeks? Sure. But the same exact risk and occurrence happens after a mastectomy alone. So having a reconstruction doesn't delay you getting treatment, and everything. Typically, chemotherapy starts 4 weeks after the mastectomy and reconstruction. So the other misconception that's out there is that all women should wait at least a year after their mastectomy and breast cancer treatment before considering reconstruction. That's also not true. But women are continuously told that. And especially for early stage breast cancers, that's stage 1 and stage 2, really there's no reason for most of those women, unless they have another medical problem that makes it dangerous, and another medical illness or disease or something. There's no reason why the vast majority of those women can't consider reconstruction. Now, the type of cancer obviously has a lot to do with it. An inflammatory breast cancer, we're not going to recommend immediate reconstruction for those instances. And there are other situations too where it's not the best idea, but for the majority of women, stage 1, stage 2 breast cancer, immediate reconstruction it gives you the best results whenever that's possible.
Okay. Now, I have another question that I'd like from a listener that I am going to just read to you as is, because it's well worded. So from this listener's understanding, with implant reconstruction, you can choose your desired breast size. Her question is, how is the breast size determined using the DEEP procedure, since it's your own fat tissue that's being used to reconstruct both breasts? For example, if there's not enough tissue to bring both breasts to the desired size, is an implant used in addition, or what happens in that situation?
Yeah, sure. That's a good question. So we used to put implants under DEEP flaps occasionally when someone really wanted to be larger. We moved away from that, generally speaking, because now you've got the added issue of the implant long term, which can give you the issue, or some of the issues I mentioned before, like the capsular contracture. Now you're introducing something into the mix that long term can potentially cause issues. So personally, I don't put implants in under DEEP flaps anywhere near as often as I used to. It has to be a very select situation, especially now with fat grafting and being able to do some liposuction, take that fat, purify it, and re-inject it to treat little contour anomalies, little areas of hollowing, improve the breast contour, make it fuller. That's just for me anyway, a much nicer way to go than putting in an implant whenever possible. But you can certainly put an implant in under a flap of tissue, like a DEEP flap. Absolutely, you can do that.
Mm-hmm. Okay. Now, most women who are diagnosed with breast cancer, one of their first consults is with a breast surgeon. breast surgeons are not the same as plastic surgeons. So I don't even know if ever or rarely do the breast surgeons do the reconstructions as well. So how do you advise women to find a surgeon to talk to about reconstruction, and when should that conversation take place in the course of, just being diagnosed?
Okay. Well, first of all, I think the patient's best advocate is the patient. So I would recommend that everyone does their research. And the best time to see a plastic surgeon who performs a lot of breast reconstruction, preferably, the best time to see that plastic surgeon is right after the diagnosis. So before they start their breast cancer treatment. That's easier said than done. There's a lot of stuff going on, a lot of advice, medical advice and otherwise, lots of confusion. It's a very difficult time. And some women feel like taking that on too, this issue of reconstruction, is something that they're not ready for. And you have to respect that. But if reconstruction is something that they do think they're interested in, I would recommend very strongly that they ask their breast surgeon who they recommend, who performs a lot of the breast reconstructions in that area. If the breast surgeon doesn't provide an answer that is acceptable to the patient, if there appears to be no reason why they can't see a plastic surgeon, but a recommendation isn't forthcoming, then I would say take it upon yourself. It's you've got to feel comfortable.
Mm-hmm. And this requires a bit of coordination. I mean, nothing about being diagnosed with cancer is easy for people, but this can potentially be another challenge because if, like you said, somebody's ready to have it, they want to have it at the same time that they have the mastectomy, ideally the plastic surgeon has to scrub in with the surgeon, and so they can get it all done together. And so it can take a little bit of work on part of the patient, I'm sure.
Absolutely, but here's where familiarity comes in. If you are lucky enough to live somewhere where there's a team that performs a lot of breast reconstruction in conjunction with the local breast surgeons, if there's that team available, then really scheduling, it's a non-issue because they've done it time in, time out, So it's not a big deal. Where the scheduling becomes a problem is if you've got people trying to get together to perform surgery on a patient. Those folks haven't worked together much in the past, or they don't do many of these procedures. So in that situation, the scheduling it can break down. Mm-hmm. But this again highlights the importance of, in my opinion, of a team approach to your breast cancer care. So there's nothing like a team approach. Mm-hmm. For all your breast cancer treatment.
Yeah, I fully agree. Well, believe it or not, we're at the end of our show. I'd like to give you the opportunity to share, if you have any resources that you think would be helpful to our listeners on this topic, please share.
Oh, absolutely. So we're very proud of our website at PRMA. As I said earlier, but breast reconstruction is what we do. So please get all the info that you need at PRMA-enhance.com. We also have close to 115,000 Facebook fans. So if you're on Facebook, please join us. It's all breast cancer survivors, breast reconstruction patients, those considering breast reconstruction, family members of patients, and that's at facebook.com PRMA Plastic Surgery. We're also on Twitter at Deep Flap Breast, DIP Flap Breast. My personal handle is M Chrysopoulo. And then we also have a great blog, Breast breast-cancer-reconstruction.blogspot.com, and that's all hyphenated, breast-cancer-reconstruction.
Great.
.blogspot.com.
Fantastic. Wow, that's a lot of resource, and I might have to keep you on the air and get all those down on paper so I can post those on our website.
Oh, that would be great.
Yeah, and our guests are very thankful for you and your knowledge. It was a wonderful show. I agree. That was fantastic. So thank you so much for sharing some of your time. Absolutely. And thank you, listeners, for joining us. Stay tuned with us all week. We have, as usual, a fantastic lineup coming up for the rest of the week. Tomorrow, one of my favorite people in the integrative health world is going to be on, Lori Knutson, who's a nurse, and she's going to be talking about resilience, a very important part of healing and health. Then on Wednesday, we have greenwashing, how to make your environment greener, meaning environmentally safe. Then we have a dietitian who will be on talking about living skinny in fat genes. And then on Friday, Carolyn and I will be back talking about some research that we've read over the week. So join us at 5tothriveplan.com to get the schedule, and follow us on Facebook and Twitter. Enjoy the rest of your evening. May you each experience joy, laughter, and love. And it's time to thrive. Have a wonderful evening, everyone.